I'm here to do a presentation, a very short presentation, but very interesting in quality control processes within the laboratory. That is what we are supposed to ensure we do, so that we can, of course, informed by the EQA performance, yes, but so that we can ensure quality results are channeled from our laboratories. So first, we are not inventing the wheel, so we have a reference, which is the gospel that we are preaching in the laboratory. We need to abide to the quality standards that relate to us in the laboratory, that is ISO 15189. Then you want to understand, as we do this presentation, you will understand the context of the quality control processes in the laboratory. And then very important is to understand the management responsibilities. I believe those who are here are decision makers, because one key thing which was discussed yesterday is the cost. So are we able to have the quality, the management support these initiatives to ensure quality is what we are talking about in the laboratory? So first of all is when these patients walk, or when patients walk into our facilities, their interest is only one. They want to get quality service. So from the laboratory is quality results that they want from us. And therefore, as a laboratory or as a scientist in the lab or the team that is testing them, we need to have that perception of what they require to have, we produce it. So it's not give anything different from that. So we have quality, what we call robust procedures. We have quality assurances in the laboratory, and then quality control processes that we are implementing to ensure that is achieved. So this was a mixed method research, whereby we did only a very short research through questionnaire for the quality, the internal quality control practices that are we that as the team we are implementing within our laboratories. But then we also did a lot of literature to get to know what is required, either from the information that others have ever been into this situation and have been able to get out of it, and of course through the ISO implementation, that is ISO 15189. Many of the laboratories that responded are in these categories: in the public facilities, in the private facilities. There are those which are from the reference lab. You can see that data, whereby most of the labs that participate in our EQA still remain private facilities, followed by public facilities at 56.5% and at 1% respectively. So fewer others now are coming in terms of reference labs, research labs, and physicians, outpatient clinics. They are also now getting this kind of info. That is, this is required. Yeah, the outpatient clinics, yes, but they need to do it right. And then blood banks and the list participation. We had respondents on this either accreditation or certification. Many perceive that maybe to participate in this quality assurance or quality control practices, you need to be going through mentorship for accreditation, but that is not there should be the perception. It should be, we speak quality whether we are accredited or certified. So 249 respondents, 54.2% are accredited to ISO 15189. 24% or close to that, they are following the guidelines, the national guidelines. I believe this now we're talking about they comply to KEMEL TTB registration requirements and regional guidelines. And then we have the others following up there now. But what should we have now? We should have, or we should establish quality standards. These, of course, are guided by now the policymakers within our organization where we work in, and of course, quality objectives. This initiative now should push us to develop a quality management system that meets the requirements. The minimum requirements is ISO 15189. Then from there now the others follow the SOPs, proper induction trainings processes, IQC, EQA, then evaluations and reviews. It is a management responsibility to ensure that they develop quality policies that can be met. And then also this should be clearly communicated that as we work, where we are working, we know what we are looking forward to achieve. And then the commitment is there for the management support in terms of financial support, impartiality, confidentiality, including even us who are working there, to meet the required competencies and qualities that now reflect in the quality of work that we do in the laboratory. So in the quality management, I know you know all this, so I don't need to deal with this so much. But this, my last point, is what I needed to emphasize on. Ensure testing processes are within control. That is very key for us. Of course, what we are talking about here are laboratory testing systems. We are referring to, I've had a lot of talk about the technologies, the late technologies, including the AI. But they should be within, now they've developed QMS within our laboratory, shouldn't speak that. This should be done by competent personnel. We ensure that we have it well documented by developing robust SOPs, verified and calibrations done, very key for us. And then this should not only be done for the equipment, it should be done for both reagent kits, and test kits that we are using, including even the consumables. Very key now, I think now they talk about the laboratory information system and AIs, then we should have them included in the verified equipment that we are working with in the laboratory. The management support is very key when it comes to competency. So now we talk about personnel who are now influencing the results that we are producing in the lab. Are they competent? Do they have the authority to perform these tests? Then very key effective review of the reports. And now my concern here is a lot in those who are working in environments where like mostly night duties, people are working alone. So who verifies the reports before they are churned out? So authority and effective review of the reports before they are released is very key for us here, which relate even to what we talk about in our reports. In the informatics, when you're submitting your reports, there is the person who has performed the reports, then there is review. That is the expectation, even what we are doing in our laboratories. Yeah? Many times, the management may forget that we need to have a say in what is supposed to be coming into the laboratory for testing. Am I speaking to the management here? Do you have laboratory directors in the room? Laboratory directors, where are you? Please raise your hands. Lab managers, are you there? Yes. So we are speaking about, please, let's be hard when it comes to procurement processes. So how are we doing it? So we ensure the consultations are there with the laboratory to ensure proper, what we call quality equipment, quality reagents, quality test kits, or even anything that comes to the lab consumables of quality. Installation, that is very key. So we have authority to what we call verification processes done, authority to operate, robust SOPs again here. And this should include even the POCTs. They should not be excluded into this. And then we have effective maintenance and calibrations where necessary. Facilities and environmental conditions, I don't want to dwell on this. This was in the notes that in case we share this, please you can cover it effectively. Reagents and consumables, I've already mentioned this. It comes still in the procurement. Very key is acceptance testing, verification performance, lot-to-lot validations, and then consumables that can affect the quality of, the examination processes. They need to be verified. So we need to demonstrate how we verify that within our labs. And then we have verification can also be based on the certificate of analysis. This is what accompanies either the reagents, the consumables. That information is what we base on the verification on. There are those who are having like service agreements with other service providers within their facilities. These including the POCT operators. Those which are not being operated within the laboratory, they are supposed to be from the authority of the laboratory. So the management support here is very key to understand the requirements of the POCT from the ISO 15189. So we need to, those who are like working in health facilities, where there is lab, there is the nursing staff, or other cadres that are using the POCTs, we need to establish a multidisciplinary POCT committee to ensure that function is well taken care of. Externally provided services. When it comes to the service providers, we need to define, review, and approve the requirements, or give the specifications. Who is this to give service to us? What are they supposed to have, including either the referral labs, the consultants, those who give services in the maintenance of your facilities, like those who will service your cold chains, what you call calibrations and what have you, including even us who give you the EQA services. And they understand that there are people even in, there are facilities that subcontract the collection and delivery of patient samples. Method verification, I've already highlighted that in the beginning. We have a procedure, yes. We look at minimally the requirements of ISO 15189, what we require to have in our method verified. And of course, continued verification processes to ensure that our equipment are still working within the specs. Proper documentation here is very key. And remember, this should also factor in the POCTs, so they are not excluded in this. Now, to ensure validity of the examination results, I've told you what we've really been able to do our questionnaire on was IQC. We've seen many of the participants from the data that you're looking at here, they factor in mostly chemistry, hematology, and POCT. So then our question is, where are the rest? Are we factoring in IQC for the other tests? Or what is happening within our facility? Maybe you can ask yourself that question. And then the acceptance, or what we call the criteria to accept the IQCs. One of them is the single range. The question was how those who use the single range limits for us is to accept the the IQC run, sorry. So you can see there is a 52.4% who will do it for all tests. Then there is 37.7 that says for some tests. And then we go down. 4.8 do not use any of the tests or any of the tests within the ranges, or they do not conform to that. So the question is, what are we doing within our facilities? Are we experiencing the same issues like as reported here? So then we have the Westgard rules. When it comes to IQCs, the strict acceptability criteria that we are using. So what are we doing? Do we employ Westgard rules when it comes to IQC acceptability criteria? So 49.2% they say for all the tests, that is 6.1 say for some tests. So what is the requirement, or what is the proposal here? To ensure validity of the examination results, IQC is very important, and we should ensure it's done, well documented, including lot to lot, and then we consider that third-party control. There was a discussion yesterday here about third-party controls, but then very key here is to look at the matrix, the stability, commutability, and clinical relevance challenge of the IQC material. I believe somebody will be talking about hematology later. Yeah. So for hematologists, remember, the platforms could not be commutable with your IQC materials, but many others could be commutable with the others when it comes to the other tests. So that's what we're talking about. The commutability is very key here. Then effective review of the IQC. We talk about what are you doing, the range, the use of LJ charts. Do you remember to look at your trends, your shifts, and then do you employ the Westgard rules when it comes to IQC acceptability? Then when IQC is not available, we don't have the excuse to say we cannot be able to work. We can. The standard gives us the alternatives, and those are the alternatives. Please look at subclause 7.3.7.2 in our ISO 15189-2022. The EQA is also very key. The second parameter to check validity of our examination results. It monitors the performance of the methods. Remember, you are looking at the accuracy of our test methods, and IQC, they should not be excluded. But then, in that, internally, we need to develop our procedures for enrollment and what have you, so that we can be able to see, even when we deviate, including the performance acceptability for our IQCs. So this is defined by you. So we may tell you is 100%, please define yours so that you can now put it into your quality indicators. Then EQA reviews, they should be very regular. Ensure that you have a specified criteria to accept your runs. And that is a bit of information about non-conforming work. So when we have the EQA failures, do we do proper root cause analysis, or do we put them under the shelves? We wait until somebody else comes to do them, or maybe we wait until the next run for EQA? Then we need to look at, are these results affecting, or have they affected the results of the patient somehow? If they have, and we have a risk of harm, then we need to do the necessary. Either we halt the testing and record the results, and if this non-conformance is to be accepted in terms of non-conforming work, we have the authority of how this non-conforming work is supposed to be accepted, criteria followed, and then we have that kind of recording or reporting, proper recording, where the risk of the patient results is there. Then we have the amendments report, or the amended reports, of course, produced. Then within our lab, we have the third method to ensure validity of the examination result, that is comparability of our methods. We are advised by the standard maybe to do either through IQC or use the patient's samples. Now here we are also considering the commutability of the sample. The IQC may not be the better material to do that if that is not working for your methods. And this actually is coming when you have two procedures that you are using or two methods that you are using within your facility. This is very handy because you need to inform the user of the clinical differences and actually demonstrate to them the acceptability, because you are now remember yesterday we also talked about our consultants in terms of supporting the clinical team. This should be done periodically, it's not a one-off thing. Then we have the management review. Remember, we've said the management support is very important. They have some of the agenda here that we cannot be able to implement until we are actually given resources. There's what we can be able to do and what we cannot be able to do. I'm on the last one, thank you. So for these, the management review meetings, we have the management in this discussion. And they actually look at one of the agenda is Part B. This is clause 8.9 in our standard. So we look at the fulfillment of the objectives and the stability of the procedures and policies. We look at the quality assurance and the validity of the results. We look at the results of participation in our EQA, and we look at the POCT activities. Of course, other relevant, very important here are like activities like training. And remember, when it comes to management support now, currently we're talking about CPD points. These CPD points, the beneficiary should be my employer first. Sorry to say that. Because remember, these skills that you are going to gain, where are you going to apply them? Where are you going to apply them? So the support for the trainings here is very key. I'm not, please do not quote me here. Do not quote me when it comes to that, but it's very key. Other relevant factors such as monitoring activities and what? Trainings. It's not me, this is the standard which is talking about that. And thank you for listening to me. I rest my case.